first of all, just thanks for asking me to talk today on adrenal disease. I think the thing to say here about adrenal disease is, the commonest, examples we see in day-to-day practice are patients, with either adrenal suppression from steroid use. But what I'm going to do really is just talk through the full spectrum of adrenal disease that you're likely to encounter in, your day-to-day practice. And then we have time for some cases at the end as well. So some kind of board style questions, which I'll run through at the end as well, just for everybody. So first of all, no disclosures. Just going to start really with adrenal insufficiency, which I think is probably one of the commonest, questions that comes up. It's one of the most common endocrine consults as well that we see as well, for good reason, because actually it presents in different ways. It's quite heterogeneous in how it presents. And so often it's about recognition and then deciding on what the best test and treatment is. So first, a little bit about adrenal insufficiency and thinking about types of adrenal insufficiency as well. So we talk about primary, secondary, and tertiary. So primary, of course, is where the pathology is usually within the adrenal glands, secondary within the pituitary, and tertiary within the hypothalamus. All of these produce the same end result, which is actually a reduction in production of cortisol. So essentially, this syndrome of hypoadrenalism. So the treatment is still the same, but often it's looking to see, well, where is the underlying issue? And that's where an ACTH sample can be extremely helpful in terms of differentiating the groups apart and just working out, where the pathology is in terms of how we investigate these patients. When we look at the patient with adrenal insufficiency, and this is one of the challenges, is the symptoms and signs that we see are very broad. And actually, the ones which are the commonest are actually, the least specific. So weakness, tiredness, fatigue, loss of appetite, weight loss, those are the ones that tend to occur in all cases. GI symptoms, are commoner in patients who are presenting with more of a severe deficiency. They'll complain of abdominal pain, nausea, vomiting. Hypotension is definitely a key factor to look out for these patients. And in terms of the electrolyte anomalies, you may see hyponatremia, hyperkalemia in some of these patients, but not in all of them. So really it's trying to sometimes put together the picture from the history, the clinical exam, and say, what does this add up to? Does this patient have adrenal insufficiency? What about the lab testing for these patients? So what we're trying to do is demonstrate that there is an inappropriately low cortisol secretion. That's number one. Number two is try to work out if there is a deficiency, is this ACTH dependent or independent, as I was saying, primary or secondary? And then finally thinking, okay, is there an underlying treatable cause? Is this medication? Is it something that we need to investigate further, such as a pituitary adenoma, or other diseases that could be infiltrating the adrenals? So what about the AM cortisol? Just checking a simple morning cortisol. And we know that, in most subjects, cortisol levels are highest in the early morning and should be, in the majority of healthy individuals, between 10 and 20 micrograms per deciliter. If we use that as a criteria for looking for adrenal insufficiency, you can see from these sensitivities and specificities, it's got some limitations. Sensitivity of about 60%, specificity of about 80%. So when we're using this test, the pre-test probability we also want to consider as well. So how likely is adrenal insufficiency in this patient? So if it's extremely likely, we're probably going to want to do more than an AM cortisol and do a corticotropin. If it's less likely, then an AM cortisol, if it's in that 10 to 20 range, is probably going to be sufficient. So it's a useful screening tool, particularly for cases where there's a lower index of suspicion. The corticotropin test we all know, and the standard approach is to give 250 micrograms of corticotropin. We check a cortisol level at 0 minutes, 30 minutes, and 60 minutes. And the reason we do 30 and 60 minutes is there are some patients who tend to peak later than that 30-minute. And so if you just do the 30-minute, there is a chance you may overdiagnose adrenal insufficiency. And we talk about setting a peak cortisol of 18 microgram per deciliter. This is based on a number of studies over time. We know that if someone does achieve that peak of greater than 18, then this excludes primary adrenal insufficiency and also makes secondary adrenal insufficiency unlikely. So why is that? So in secondary, as I was saying, these patients produce less ACTH, so their adrenals, over time, we see atrophy of the cortex, so they also will have a subnormal response on this test as well. So what are the key situations that come up, I think, day to day in adrenal insufficiency that we need to consider? So I think exogenous glucocorticoids, as I said at the start, is a really important one. And I'm also going to just mention other medications out there which can also result in adrenal insufficiency to one degree or another. I think it's important to talk about the patient who's in adrenal crisis. And I think also practically, you know, what we tell patients with adrenal insufficiency when they're dosing their steroids for procedures or other times of illness as well. So if we look at the evidence that's out there for exogenous glucocorticoids and suppression of the HPA axis, it's safe to say that if a patient is on more than 20 milligrams of prednisone and they've been on that dose for 3 weeks plus, they will have adrenal suppression. That's a given. If they're on a smaller dose for over that 3-week period, let's say 5 to 20 milligrams, it is, you know, there is a good chance they may have adrenal suppression. And in those cases, there's an argument to make some level of assessment. If they have an AM cortisol of over 10 micrograms per deciliter, that means adrenal suppression is going to be unlikely. If it's equivocal, 5 to 10, we can consider doing Cortisol if we're wanting to make a more detailed assessment. If it's less than 5, they're clearly suppressed, and these patients will need intravenous steroid cover during procedures. So this is important for the patients who are on long-term high-dose prednisone coming up to surgical procedures. You know, we really want to make sure they've got cover with steroids during those episodes. What about other drugs? And I think some of these are known, some less well known. So we know that, interestingly, opioids suppress the HPA axis, and for patients on a morphine equivalent daily dose of 100 milligrams plus, we can see adrenal axis suppression in 10 to 50%, and that can be clinically, you know, significant in a number of those patients. They may present with the symptoms of hypoadrenalism, but of course there's an overlap because they're also on the opioids, so it can be really difficult to kind of unmask some of those. There's another group of drugs called the immune checkpoint inhibitors, and you'll see these patients occasionally coming in through the emergency room. The classic example is a patient who's maybe had melanoma and they've been given one of these drugs, ipilimumab or Opdivo, and they're coming in with a low blood pressure. And what these drugs tend to do is cause loss of ACTH production. They produce an immune response in the pituitary and hypophysitis, and that results in a secondary hypoadrenalism. So these patients all usually have low ACTHs, low cortisols, and the key treatments I'll be talking about in a moment for these is to give steroids and fluids and then assess further. But it is something we're seeing more of with these drugs. Interestingly, the patients who are more likely to get adrenal insufficiency with these drugs are often the people who've responded the best in terms of the treatment of the underlying cancer, because they get a more profound response. And then finally, magestrol is another one to mention, a high dose progestin that's used in breast cancer patients at higher doses. Also, we see adrenal suppression insufficiency in patients on that. So it's just good to be aware of those, really. For the patient who's coming in an adrenal crisis, the key things to say, a lot of these symptoms you would expect, so dehydration, hypotension, particularly shock out of proportion to the severity of the illness. So someone who's got a low blood pressure can't quite explain it from the rest of the history. A lot of GI symptoms, may have symptoms mimicking an acute abdomen, often may have hypoglycemia because that's common in these patients too, the electrolyte anomalies, and sometimes there may be other associated endocrine deficiencies as well, particularly Hashimoto's disease or autoimmune hypothyroidism, which occurs more commonly in these patients. So I think the key thing to say with a patient who is considered to be in a possible adrenal crisis that, you know, we want to start therapy early, but draw the labs really at the point of admission for cortisol and chemistry. We can also draw an ACTH at the same time, and start treatment where we're considering this diagnosis of adrenal crisis. And the treatment is, as you'd expect, is really getting good IV access, replacing with isotonic saline, and giving hydrocortisone and 100 milligrams intravenous bolus, followed by 6-hourly dosage as well. And really, it's about really getting that treatment started for those patients promptly where we're considering an adrenal crisis. What about adrenal insufficiency then, as we treat them through that crisis? What about them thinking about how we dose their hydrocortisone? And this is another area which is good just to reflect. So typically, we know how much cortisol is produced from the adrenals over a 24-hour period, and that equates to about 10 to 25 milligrams of hydrocortisone in 2 or 3 divided doses. So a majority of patients with Addison's disease or adrenal insufficiency will be in that dose range between 10 and 25 milligrams. And just to give a comparison there, hydrocortisone 20 milligrams is equivalent to prednisone 5 milligrams. We tend to prefer hydrocortisone for patients with adrenal insufficiency, just because we see less side effects, less glucocorticoid side effects, lower risk of osteoporosis compared to prednisone. The main thing to say about hydrocortisone, in relation to prednisone, however, is though that it has to be given in 2 or 3 divided doses. And we'll often give the majority of the dose in the morning, so maybe 15 milligrams in the morning, and then 5 or 10 milligrams in the early afternoon. And what we're trying to do there is mimic the normal diurnal rhythm. During illness or during acute illness, when someone's acutely unwell with adrenal insufficiency, we are giving often, particularly for someone who's having a procedure, we're giving a stat dose of IV hydrocortisone before induction of anesthesia, and that will be 100 milligrams of hydrocortisone, and then 50 milligrams every 8 hours. And then a standard approach, once the patient's eating and drinking, will be to double their usual oral dose for a period of around 3 days, sometimes longer, and then taper to the home dose. For the patient with adrenal insufficiency who's complaining of fever or other factors, I'm going to highlight here a really good website for anyone who wants to read a little more on this. It's the National Adrenal Disease Foundation. They've got the website here, www.nadf.us, and they've got some really good guidelines, one of which this link will take you to. And in those guidelines, it just gives you a kind of idea of what we recommend for patients taking hydrocortisone who are unwell. And to give one example here, for a high fever, we may recommend to triple the dose of hydrocortisone. We're trying to mimic that normal glucocorticoid rise we see during fever. For someone who's got a lower fever, maybe a double dose for 3 days. So we're trying to really cover that period of acute illness. And so that gives you an overview of what we're trying to do for those patients there. So just that's been a run through adrenal insufficiency and just some of the key points we tend to consider in these patients. What I'm going to do next is then talk about the other real broad area of adrenal disease that you're going to see in inpatients, and that includes the adrenal mass. And as part of that, syndromes of adrenal hypersecretion, so excess hormone production in these patients, and then we'll move on to some cases after that. So this is a term, we all see. So it's incidentaloma. What is that? It's something we see a lot, particularly in inpatients that we're looking for. A patient may have had a CAT scan for a separate reason, and on the report, there it is. 2 centimeter adrenal mass noted. So actually, often, these are discovered incidentally to another pathology. Once we've found them, then it's really then determining what is the appropriate course of follow-up for that patient. And, in terms of these kinds of cases, these are people that, we do see in the endocrinology clinic for additional workup. The kind of things we're looking at is really to make an assessment of what is the size, is it secreting excess hormone, yes or no. So it's really looking to see how active it is metabolically. And they've actually studied this. When we look at incidentalomas, what proportion of these are non-functioning. And actually, it's about 3/4 of these incidentally found masses are metabolically inert, do not produce any hormones. If we look at the ones that are secreting, it's relatively small percentages. So about 2.5% for COM syndrome, so aldosterone excess, maybe about 5 to 10% for Pheochromocytoma. The one we really want to be cautious about is Adrenocortical Carcinoma. that's under 10% as well. Occasionally, it may be a metastasis. So particularly for a patient who's got other history of cancer, may want to be considering that. So as you can see, a majority of these are going to be non-functioning, but we want to really select out those cases where there is hormonal excess. And the way we do this is when we're assessing them, particularly in clinic as well, we're asking two questions in parallel. We're asking, is this a malignancy? Is it biochemically active, as I say? And the ways we can look for the characteristics and to see if there's signs or concerns regarding malignancy can include, as well as size, we can look at the number of Hounsfield units. We can look at what the washout is on the CT scan. For a patient who has a history of other cancer, you do FDG PET to look to see if the lesion is highly metabolically active, versus more benign radiology, where the size is under 10 centimeters, the Hounsfield units are under 10, and a very homogeneous density. So that gives us at least an idea in terms of how this lesion may be. In terms of clinical assessment, we really want to check for the key three syndromes, Cushing's, Cons, and Pheochromocytoma. And a good screening test for Cushing's is the 1 milligram overnight dexamethasone suppression test, with the dexamethasone given usually in the late evening, and then the cortisol drawn the next morning. We often draw dexamethasone along with the cortisol just to prove that the dexamethasone was taken. So when we're interpreting the result, we can interpret that correctly. For pheochromocytoma, a standard test is to do urinary metanephrines. We can do plasma, but they tend to be, they can have challenges. So if they're drawn in clinic, particularly if the patient is extremely anxious, that can cause those to be elevated. So the 24-hour urine test is preferred. And then the other tests we will do will be the aldosterone-renin ratio, thinking of Cons, and also adrenal androgens, thinking of less commonly, but occasionally we may see an androgen-secreting adrenal tumor as well. That will usually manifest with hirsutism, etc. So you'll see symptoms and signs of that. So adrenal masses, incidental adrenal masses are extremely common. So 1 in 10 patients autopsy will have an adrenal mass. That gives you an idea of how common this is. And so that really is one of the things to bear in mind when we're looking at this. And so I've talked about the 4 main groups. So that's cortisol excess, Cushing's syndrome, Cons syndrome, Hyper-Oldesterianism, Pheochromocytoma, and a viralizing tumor, which is rare, thankfully. So we talked about malignancy risk. What are we looking for? So generally benign nodules are going to have a higher fat content. They're going to have a low density, a rapid washout, versus a more malignant lesion, which is going to have a higher density, less contract washout. So it's often going to be very clear from the radiology report that we're looking at something of more concern. Pheochromocytomas tend to have higher density. If it's under 10 Hounsfield units, generally these are going to be benign nodules, we find. In terms of management, for growths that are more than 4 to 5 centimeters in size or have more of a concerning appearance or are hormone producing, those are the kind of patients we're going to be thinking about referring for surgery. But masses that are under 4 centimeters, we're going to recommend really imaging those again in 6 to 12 months to look for any signs of growth, along with performing hormonal testing for these. So I'm going to move on and just talk through some of the examples of cases of adrenal hypersecretion, how they may present and how we may approach those as well. So Cushing syndrome, the symptoms of this typically are going to include weight gain, muscle weakness. Question I think we often ask people in clinic when we're thinking about this is saying, can you get up from a squatting position? And the patient who's got established Cushing syndrome will have real difficulty doing this because of the proximal myopathy they tend to develop. They really develop a marked proximal muscle weakness. They'll often have quite marked stretch marks, acne, facial rounding, all of those features. And in terms of signs, again, another good question to ask is if they've found that they're tending to bruise more easily. That is a common thing that we see. We look for facial plethora, history of osteoporosis, hypertension, signs of insulin resistance, such as acanthosis. So all of those features, putting it all together can really drive us to think about Cushing's. in terms of how these present, it can vary from the extremely subtle to the kind of, really obvious Cushing's case. Really is a spectrum that we see. And as I said, the 1 milligram overnight dexamethasone suppression test is a really good starting test. We want to see that suppressed to less than 1.8 microgram per deciliter on the overnight test. The other tests we do include the 24-hour urine, the late night salivary cortisol, because we know that cortisol in the evening really tends to be at an extremely low level. And by giving the patient a saliva swab to take home, the way they can check their late night salivary cortisol, that allows us to look for loss of diurnal rhythm that we can see in Cushing's as well. And the differential diagnosis, when we look at this, the majority of patients with Cushing's syndrome, interestingly, are not adrenal Cushing's, but are actually, the Cushing's, what we call Cushing's disease, so ACTH dependent. So in a majority of cases, the pathology is actually in the pituitary, not in the adrenal. And again, drawing an ACTH at the time of diagnosis really helps tell these two apart. We expect to see a low ACTH where the pathology is in the adrenal versus high, although it can be in normal range, inappropriately normal range, we might say, so maybe in mid-normal range in the patient who has ACTH dependent Cushing's. And occasionally we will see patients with ectopic ACTH, often a malignancy that can be triggering this. So as I said, once we've measured the ACTH and really worked out where the underlying pathology is, the next step then is to move on with imaging, and that's either going to be imaging of the adrenals versus MRI of the pituitary, depending upon where the biochemistry is directing us. And I think that's the key message, is that the biochemistry here comes, really guides where we go with our imaging. So questions that can come up in relation to patients with Cushing's and are often, common exam type questions can be a patient who has signs and symptoms, and what's the best diagnostic test to confirm Cushing's. Maybe a patient who's got ACTH dependent Cushing's, and the ACTH is in the high normal range, which is inappropriate if they've got an extremely high cortisol level, and that's again pointing you to the pituitary rather than the adrenals. I think it's then knowing what the next steps are in management for these patients. So moving to an MRI of the pituitary where we're considering that diagnosis. So moving on from Cushing's, in terms of these patients that we see, the next group will be Pheochromocytoma. The majority of these patients will have established hypertension and will complain of sweating episodes, headaches and palpitations. So this kind of triad of symptoms that we see. May also complain of nausea, anxiety, may appear very pale during these acute episodes. It's actually extremely rare. I think that's the important thing to say, but it's, when you do see a patient with this, the symptoms are very classic. And often, if a younger patient with extreme hypertension, you're guided towards considering this diagnosis by the way they present, I find. And in terms of the diagnosis, 24-hour urine, metanephrines is really the best initial test. We do use plasma metanephrines as a kind of follow-on test, which has a high sensitivity, but a lower specificity. For the reasons that I said, in the clinic setting, the patient's extremely anxious, we can see elevations due to that. In a true Pheo, the values on the urine are going to be 2 to 3 times the upper limit of normal. So they're not just going to be slightly above normal range, they're going to be 2 to 3 times the upper limit of normal. And that's another key factor with pheochromocytoma to say as well. It's good to be mindful when a patient has had metanephrines and they're elevated and we're thinking what to do next, that there's quite a long list of drugs which can cause elevation. And, typically, if they are on these drugs and it is causing elevation, they're going to be in that marginally elevated range as opposed to 2 to 3 times the upper limit of normal. But this gives you a list of example drugs, decongestants, prochlorperazine, to name a couple there, and alcohol as well. A few of these can result in this effect. And then moving on in terms of imaging, once we biochemically confirm the diagnosis, we tend to move to CT or MRI. And following that, MIBG, which is very specific for Pheo, but less sensitive. So we tend to do that after the initial imaging, and it can be particularly useful in large tumors if we're concerned of metastatic disease, so metastatic pheochromocytoma. And the treatment, for these patients really is prior to surgical resection, is ensuring they're on alpha blockade. We will use often phenoxybenzamine, a very old alpha blocker, but we sometimes also use doxazosin. And the key message there is we don't add the beta blocker until we've got them adequately alpha blocked. And the reason being is if they're not fully alpha blocked, you add the beta blocker, you can precipitate a crisis. So we have to, that's the reason we do it in that order. And common questions that can come up, in exams for these types of patients, are where patients may present with signs and symptoms of pheo and working out what's the appropriate labs and imaging to establish the diagnosis, and knowing really that you really want to do the alpha blockade, and most people know this, before adding the beta blocker, to make sure that we avoid any issues there. So that's Cushing's and pheochromocytoma. Another one to think about is primary hyper-Oldesterianism. And I think the time to think about this is where you've got a patient who's got extremely difficult blood pressure to control, who's adherent with their therapy, particularly in younger patients, on multiple agents. Often these patients are on 3, 4, or 5 agents. They may be hypokalemic, but not always. So those are kind of things which guide you towards thinking about this diagnosis. If we look at the aldosterone-renin ratio, if it's greater than 30, it tends to be strongly suggestive of primary hyperaldosteronism. If it's lower than that, it's much less likely. It's always good to think about how medications may impact this ratio. We know that there are particularly a few medications which can cause false negatives. So it's good to talk through that. The medications which will do this, and the ones I've underlined here, probably the 2 key ones to be mindful of, is that if we're doing this test, we do not want the patient to be on a mineralocorticoid receptor antagonist like spironolactone or a direct read-in inhibitor, one of the newer agents. ACEs and ARBs and beta blockers can all affect the ratio, but to a lesser degree. So in terms of making a diagnosis, the 2 key ones we tend to want to substitute with an alternative, drugs like aldosterone or direct renin inhibitors. We can go ahead and do the test if someone is on an ACE inhibitor or an ARB or a beta blocker. Where we may then want to consider additional testing is if we get a more borderline or equivocal result. So in terms of imaging in hyperaldosteronism, so when we look at CT of the adrenal glands, we're looking to see, is this a solitary nodule versus bilateral lesions? And you can see either. It's really interesting. And so if it's bilateral, we will treat these patients medically with either spironolactone or a pleuronone, which is a newer mineralocorticoid antagonist. They're extremely effective at getting good blood pressure control and essentially medically treating this. If it's a solitary nodule, then we would definitely consider referring for adrenalectomy for those patients where it's appropriate. Other cases to be aware of when you see the adrenal mass, less common but still out there, are adrenocortical carcinoma, and the imaging characteristics will all often be a big clue here. As I'd mentioned earlier, very high Hounsfield units, delayed washouts. There may be a history of extremely rapid viralization, so a patient may complain of rapid change in increasing hair growth, and maybe a really over a few months even. And so that's something to consider in those patients. Adrenal metastases, that's where you're going to be seeing something on the CAT scan in the history, with the history of pre-existing malignant disease often. And that's where we often will use PET imaging to look to see and confirm if this is a metastasis, to decide what the appropriate management will be there. And this next slide just summarizes what I've been saying there about imaging, which I think is the key to adrenal disease. Besides the biochemistry we've discussed, we're thinking about size, growth rate, shape and margins, composition, effects on washout and attenuation on CAT scan, appearance on MRI, and finally the use of FDG PET. And I think if we use that information, it can really help guide our management of these cases. And this last one here on looking at incidentalomas, just summarizes what I've been saying in terms of our approach. So adrenal incidentaloma, we look at the size. If it's less than 4 centimeters, we're going to be much less concerned. If it's less than 10 Hounsfield units, again, lower concern. If it's more than 10 Hounsfield units or more than 4 centimeters, again, those are features which are going to drive us more to assess with additional imaging or refer the patient to surgery. And then again, biochemical evaluation, when we look at that, we're going to think, okay, what's the next appropriate step in terms of treating this for the patient? So that's kind of been really just a broad overview of adrenal insufficiency, the adrenal mass, the incidentaloma, and syndromes of adrenal hypersecretion. What I'm going to do now in the latter part of the talk is move into some cases, some practical cases, which we'll talk through, and then we'll bring things to a close. So first case, what I'm going to do for this is really just use the chat box will be fine. Feel free as I get to the questions, just to type in A or B, C or D, just have a look at the question, and then I'll run through the answers. So first case is a 43-year-old male who's been referred for evaluation of resistant hypertension, hypokalemia, and he's takes amlodipine, carvedilol, and spironolactone. He's also on metformin and potassium, and he's got a blood pressure of 148/96. And so he's had his aldosterone and renin activity measured by his referring physician. His blood pressure at the appointment was 133/86. He feels generally quite well. His potassium was 140, so his potassium was 3.6, his sodium 142, his serum aldosterone 35, and his renin activity less than 0.6. So suppressed renin and a higher aldosterone level as well. So the first question is, what of the following is the next best step in this patient's evaluation? So should we stop the amlodipine and repeat the aldosterone renin? Should we stop the spironolactone for 2 weeks using alternative blood pressure agent if needed, and then repeat the test? Should we do a CAT scan, an adrenal MRI, or start a pleuronone? If anyone wants to put some answers just in the chat box there, that's fine. We'll have a look. Great, and I'm getting lots of 2s. That's brilliant. Okay, fantastic. Well done. Yeah, 2 is exactly the correct answer. Well done. So really, this patient is on one of those 2 drugs which really can have a problematic effect here on this ratio. So spironolactone, we're going to say stop this for 2 weeks. We're probably going to want to watch what happens, because if he really does have Con syndrome, as soon as we stop that, his blood pressure is going to rise. So we may want to check he's got ability to check blood pressure at home and can alert us if his blood pressure is rising. And then we're going to repeat the test after he's been off this for 2 weeks to get the answer. So number 2 is the correct answer. Well done. Yeah, that's great. And again, for when we're looking at these groups of patients, that aldosterone renin ratio, we look at approaching these patients, and I talked about adrenal CT. We do use adrenal vein sampling for these patients, particularly if we're wanting to double check for lateralization. And that's where we'll really refer this patient to interventional radiology, and they'll sample from both adrenal veins. And we're looking to see that there's a really clear gradient there. And that's very important before we refer for surgery. We want to be 100% confident that one of those adrenals is the culprit. And that's particularly helpful for those. And for a lot of these patients now, they are treating with laparoscopic adrenalectomies as well. So it's a minimally invasive surgery, which is another good thing as well for these kinds of patients. Great. So case 2 is a 54-year-old man. He's got a 2.2 centimeter mass in the left adrenal gland, which was incidentally found on a CAT scan, so classic incidentaloma. And the CAT scan had been done to evaluate him for hematuria. It's homogeneous. It's actually 30 Hounsfield units with 30% washout 15 minutes. So quite high on the Hounsfield units. His blood pressure is 122/78. He's not getting his symptoms of sweating, palpitations, or headaches. He's not on any medications, but there's a positive family history of hypertension developing after age 50 years. And on his screening test, his plasma metanephrines were actually 670, which is actually around 3 times the upper limit of normal. His plasma norepinephrines were 641, which is more than 3 times the upper limit of normal. His cortisol after 1 milligram of dexamethasone suppresses really nicely down to significantly less than 1.8. So this is the key message, is that he's got marked urinary metanephrines, which are 3 times the upper limit of normal. And this was his CAT scan. I'm just showing here with the arrow just pointing to this larger adrenal nodule. This was a pre-contrast CAT scan there. And the next question is, what's the next appropriate best step for this patient with these findings? So is it to prescribe an alpha adrenergic blocker and then refer for adrenalectomy? Number 2, should we measure plasma renin activity and serum aldosterone? Number 3, should we do an adrenal MRI? 4, repeat the CAT scan in 12 months. Or 5, perform an adrenal biopsy. Any answers there? Get some people to type in. Okay.
It's okay to be wrong, guys. Take your best guess. There you go.
Great. Brilliant. Oh, well, good stuff. Yeah. Okay. So number 1, yeah, great. And that's exactly right. It really is exactly the message here is this is a clear-cut pheochromocytoma. We're going to start alpha blockade. This patient's going to need surgery. So that's exactly the right way to go for this patient. So pretty straightforward, pretty clear-cut, but just helpful just to talk about that. Just to mention, we very, very rarely do adrenal biopsies. They rarely yield useful information. Most of the information we need now we can get from imaging and biochemistry. And actually, if there is, for example, for a patient who's got malignant disease, you can see seeding of the malignancy along the track of where the needle was. So actually, that's something we tend not to do for those kinds of patients. Okay, so case 3 is 67-year-old man who's got another incidental, right-sided adrenal mass on a CAT scan performed as a fault for colon cancer. He had had a previous partial colectomy and chemo 2 years ago, and his adrenal glands were normal on CT imaging a year ago. So a year ago, everything looked good with the adrenals. So it's fairly rapid onset. And he's now got this 3.2 centimeter right adrenal mass, which has 27 Hounsfield units with 35% contrast washout. So again, elevated Hounsfield units above that, significantly above that 10 cutoff we were talking about. His blood pressure is normal, and he's got normal glucose, potassium, metanephrines, and he suppresses well on an overnight dexamethasone suppression test down to 0.8. So good suppression there. So the question here is, what's the best step for this patient with this adrenal mass in the context of a history of colon carcinoma? So first, number 1, should he be referred for an adrenalectomy? Number 2, should we do an MRI with additional imaging to look to reassess? Should we do an FDG PET scan? Should he have a repeat CAT scan in a year, or should we measure serum aldosterone and plasma renin activity? Great, so I'll get people just to put a few answers in there. Anybody want to have a go at that? Nice. I've clearly made these questions too easy. It's well done, everybody. No, you've done a great job. That's great. So three is absolutely right. So FDG PET is a really good test here, and as I've mentioned just earlier on in today's presentation, for a patient where you're considering malignant disease and you're wanting to assess if this is a metastasis, this is a really good way of helping determine that and really preventing unnecessary treatment. So it really is trying to guide the best treatment plan options. That's really useful for this kind of case. Okay, so case 4 is a 55-year-old woman who's been referred for a right adrenal mass, and she's had a history of flank pain. So again, it was incidentally discovered. She was normotensive. She's got no signs of adrenal gland dysfunction. She's on a bisphosphonate for osteoporosis. The mass is 3.4 centimeters in diameter. There's very low on the Hounsfield units. There's more than 60% contrast washout at 15 minutes. There's no nodularity on the left adrenal. She's got an elevated blood pressure, but otherwise no real signs of Cushing's that you can see. And here are her lab results. So she's got a plasma ACTH, which is actually below normal range at 7. And it was repeated, it comes back at 8, so normal range 10 to 150. When she had serum DHEA, which is an adrenal androgen, which is driven by ACTH secretion, so tends to decline when ACTH is low, is also low. A serum cortisol after 1 milligram of dexamethasone is 4 micrograms per deciliter and should have suppressed to less than 1.8. And a urinary-free cortisol also was tested, although interestingly that was in normal range. Her plasma norepinephrines were normal, and her plasma metanephrines are normal as well. And then the next question is, how would you counsel this patient about the adrenal mass and test results? So answer 1, she should not consider surgery unless the adrenal-free cortisol is elevated. 2, the degree of cortisol excess has no clinical consequences. 3, the risk of developing critical cortisol excess is less than 5%. 4, her osteoporosis is unrelated to the adrenal tumor. Or 5, the adrenal tumor may increase her risk of cardiovascular events. So I'm going to get everyone just to type their thoughts in the chat box there. Good. Yeah, great. So that's great. So 5 is absolutely the right answer. So, for this patient here, there's signs pointing towards cortisol excess. The urinary-free cortisol can have a pitfall, because if you're doing a cortisol, you would always want to have a 24-hour creatinine along with the cortisol. So we do something called the cortisol creatinine ratio. So by itself, it's not the best test just to have the cortisol. The overnight dexamethasone suppression test, if we've had 2 of those, that is convincing that she does have cortisol excess, and the main cause of mortality in these patients is cardiovascular events. So that is absolutely correct for this one. And when we look at morbidity and mortality in patients with generally with an adrenal adenoma with Cushing's, we really see for those patients, and if you look at the green line, and all-cause mortality for these patients, and the blue line and the green line actually, versus the red line, which is stable non-secreting tumors, both all-cause mortality and cardiovascular specific mortality is increased in these patients. So, summary. So what I've hoped to do there is really just give, just a general overview. And I think really in terms of adrenal insufficiency and relation to adrenal disease, the use of the AM cortisol versus the cosintropin, I think, in a majority of cases, the AM cortisol is practically the most straightforward test that we want to do. If we've got a very high index of suspicion, for those patients, cosintropin is the right way to go, because again, if everything's pointing towards a very high risk of adrenal insufficiency, the AM cortisol, the sensitivity and specificity is going to let you down on that test. But on the converse, for a patient who's relatively low risk for adrenal insufficiency, the AM cortisol, if it's greater than 10, you can confidently say this is not going to be adrenal insufficiency. It's always good to think about, is this patient adrenally suppressed? It's good to try and get a history of steroids. The other thing to think about is, have they had steroid injections as well as being on prednisone? So anything that could be suppressing their axis. And, for adrenal insufficiency, often thinking about, getting treatment started before we've got all the pieces of the jigsaw and the diagnosis is clear. That's the truth of it. For the incidental, it's actually surprisingly common. We know that probably around 10% of patients who've got an incidental finding of adenoma on a CAT scan will have autonomous secretion. So for that reason, we can justify screening these patients for a hormone excess. So it really is worth, when we're finding this, making sure that these patients have some form of endocrine follow-up longer term. The best initial test is always going to be a CAT scan for these patients of both adrenal glands, and then taking that in conjunction with the biochemistry in the presentation, we take things forward from there. Pheochromocytoma, autonomous cortisol secretion, and hyper-Oldesterianism should be excluded in every case of incidentaloma. Also, we should be thinking about these in the patient who presents with an atypical hypertension, a younger patient, plus or minus hypokalemia. And I think this is a key point, is that, you know, when we're looking at referring a patient for surgical treatment, we're wanting to look, you know, what is the long-term outcome for the patient? What's the effect of the hypersecretion on their comorbidities, etc. You know, but for a majority of patients, these will be referred to the surgical team, to the endocrine surgeon as well. Thank you very much. Thank you for your time. Thank you for listening. Any questions?